Opioid use disorder, addiction and treatment. The primary objectives of this lecture are to define opioid use disorder, discuss the medications involved in addiction, and learn how to treat addiction. Here's some 2016 numbers of the opioid epidemic. It is an increasing problem affecting over 2.4 million people in the United States, and this number continues to grow. This presents a large economic burden to the healthcare industry with a cost of opioid misuse of around $55 billion. This cost to the healthcare industry is problematic, but what is really staggering is the amount of people who die from overdoses or opioid misuse. 1 out of every 8 deaths are related to an opioid in young adults, 25 to 34 years old. We need to understand how patients become addicted to these medications in order to help them successfully treat their addiction. The opioid receptor is the main receptor involved. This receptor can be activated by agonists such as heroin, oxycodone, or hydrocodone, or can be blocked by antagonists such as naltrexone and naloxone to reverse an overdose. When the bodies respond to pain, we produce hormones such as dynorphins, endorphins, and endomorphins, which bind to the opioid receptors. These receptors are mainly found in the brain, spinal cord, and digestive tract. These endogenous opioids provide pain relief. There are several types of opioid receptors. The mu receptor is the main opioid receptor in the body, which can be broken down into 2 subtypes. The mu1 receptor is associated with analgesia properties, while the mu2 receptor is associated with respiratory depression and constipation. For example, morphine binds strongly to the mu receptor and produces a variety of effects such as euphoria, nausea, itching, and constricted pupils. Of all these side effects, respiratory depression is the most concerning and can be fatal in an overdose. The Kappa receptor is another type of opioid receptor associated with the analgesia properties and sedation, but does not produce the euphoria effects as seen with the mu receptor. Another difference to consider is that mu receptors block all pain signals in the body, while the Kappa receptor only blocks pain produced by non-thermal stimuli. Another commonly prescribed opioid is fentanyl, or Doragesic, sold as transdermal patches. This medication has a high abuse potential by eating or smoking the patch contents. Some heroin dealers take fentanyl patch contents and mix this with heroin in order to sell more product. When opioids are prescribed, clinicians should prescribe the lowest effective dose. To evaluate the dose of an opioid, morphine milligram equivalents, or MME, are used. The morphine milligram equivalent should not surpass 50 MME per day. If necessary, and on a patient-specific basis, titration should be used when increasing doses up to 90 MME per day. Another important point to remember is that long-term opioid use often begins with treatment of an acute pain event. Prescribing opioids should be limited to 3 to 7 days of therapy for acute pain. Titrating opioids to higher doses is associated with increased risk of overdose and death. Trials have shown that increasing dosages does not reduce pain over long periods of time. One trial found no evidence in pain between doses of 52 MME compared with 40 MME. Patients can achieve pain relief safely with lower doses of opioids. This table shows how to convert commonly prescribed opioids into morphine equivalents. Not all medications have the same IV to PO ratio, and it is important to keep in mind the relative potencies when choosing a medication regimen for patients. For example, hydromorphone is 5 times more potent when given intravenously compared to the oral formulation. To calculate the daily MME, follow these 5 steps. Simply add the total daily dose of current opioid prescription, locate the ratio of morphine equivalent for the current opioid, multiply the dose by the MME equivalent, and repeat for each opioid medication. Then you add all the MMEs for the total daily MME. Let's take a patient case. This is a 23-year-old male, prescribed Percocet for post-op pain following wisdom tooth extraction. How many MME per day is this patient receiving? So we follow the steps, add up the total daily dose of the patient's current opioid prescription, then refer to the MME chart to find the ratio of morphine to the patient's current opioid. Then we calculate. We repeat this calculation for all the MMEs for the patient's current opioid prescriptions and then add them all up to get the total MME per day. Patient AB in this case is receiving 60 MME per day to manage his pain. Here are some more examples of what 50 MME per day and 90 MME per day would be for a typical prescription. The numbers 50 and 90 sound like liberal allowances for the maximum dose patients should be prescribed, but it actually is quite small. For example, only 10 tablets of Norco reaches the 50 MME per day allowance. These 10 tablets would be appropriate for an acute pain prescription, yielding a 3 to 7 day supply. So once a patient has taken all of their opioids for their acute pain, some patients experience pain beyond this time and they desire more opioid medication. This is often the starting point of opioid use disorder if a patient becomes dependent on the opioid medication for longer periods of time. Not all patients experience this, but it does happen. Warning signs to look out for include requesting early refills, misusing their medication such as taking the medication more frequently than prescribed, doctor shopping, and demanding higher doses. Misuse of medication can lead to dependence in some patients who are at greater risk. These higher risk patients may be predisposed to dependence through genetics, other medical conditions such as a mental health disorder, prior substance abuse, or low pain tolerance. It is important to closely monitor these patients and look out for those red flag warning signs to see if they develop drug-seeking behaviors. If you suspect your patient could be experiencing opioid use disorder, it is important to establish a trusting relationship with them and to begin a conversation with them about their behavior. The patient may be aware or unaware that they are becoming dependent and or addicted to their medication. Options for treatment can be provided, such as support groups and counseling, and pharmacologic options including methadone, buprenorphine, and naloxone. To understand how the opioid receptor works, let's look at the opioid receptor with a full agonist, such as methadone, versus partial agonist, such as buprenorphine, and an antagonist, such as naltrexone. When an opioid binds to the opioid receptors, they bind as full agonists, causing the sensations of euphoria and pain relief. Buprenorphine binds as a partial agonist to the opioid receptors, which prevents the opioid medication from binding while still providing some pain relief for the patient. Because buprenorphine is a partial agonist, the patient will not experience rapid withdrawal symptoms and can comfortably taper off their opioid medication. Another medication to consider is naloxone, which is an antagonist at the opioid receptor. Because naloxone is an antagonist at these receptors, it prevents the opioid medication from binding, but does not provide pain relief for the patient. Naloxone is often combined with buprenorphine, so the patient will have some pain relief while tapering off their opioid medication. The graph on the right shows how increasing doses do not have an increasing effect. Withdrawal is inevitable when helping a patient recover from opioid addiction. Some patients can experience withdrawal symptoms as early as 6 hours after the last dose of their medication, while others may experience withdrawal symptoms a few days after the last dose. Counseling patients on the withdrawal effects they will experience is important so they can successfully complete opioid addiction treatment. Symptoms to be aware of include cravings, anxiety, agitation, abdominal cramps, myalgias, fatigue, and sweating. The Drug Addiction Treatment Act of 2000 allows providers to treat opioid addiction with Schedule 3, 4, and 5 medications. Currently, buprenorphine is the only FDA-approved treatment for opioid addiction. Providers may register to prescribe buprenorphine and may treat up to 30 patients in the first year once this registration is obtained. After the first year, providers can request to treat up to 100 patients. Buprenorphine acts in two ways to treat addiction. The partial binding at the mu receptor provides some pain relief to the patient, while the antagonizing the Kappa receptor provides relief of constipation and respiratory depression. Buprenorphine is unique to have a high affinity for these receptors, which prevents opioids from binding for longer periods of time. Additionally, to the long duration of action, buprenorphine has a relatively quick onset of action of 15 minutes. This medication is a great choice for patients because of its many unique formulations. Having options for different medication formulations allows better compliance for patients. For example, patients who may have a history of non-compliance or who do not want to take medication every day, the patch would be a good choice due to its once-weekly administration. Buprenorphine also comes in an injection and a sublingual dissolvable films or tablets. Due to the mechanism of being a full opioid antagonist, naloxone is often used in overdose situations in which the patient is unresponsive. Naloxone can be administered by injection or intranasally to quickly reverse an overdose. Doses may need to be repeated if the patient is still unresponsive, given the short duration of action of the naloxone. Suboxone is a combination of buprenorphine and naloxone given in a variety of formulations similar to buprenorphine. This medication must be prescribed and is dispensed in a pharmacy and is not available over the counter. Suboxone is made as sublingual films and sublingual tablets in a wide dosage range. Another medication option is to treat addiction is methadone. Buprenorphine and naloxone and methadone are all efficacious therapies. However, methadone has several benefits which may lead to longer treatment retention. With methadone therapy, patients are often required to get the medication from a clinic, and it is an inexpensive treatment option. Methadone has been a mainstay of therapy for over 50 years to treat opioid addiction. In order for clinics to dispense methadone to patients, the clinic must register through the Substance Abuse and Mental Health Services Administration. Methadone is metabolized through common CYP450 enzymes 3A4 and 2D6, and its use should be monitored for drug-drug interactions if patients are taking medication also metabolized through these enzymes. Patients should be counseled on the side effects of nausea, vomiting, sedation, and constipation. Close monitoring is recommended for respiratory depression and QTc prolongation. Pregnant women who require therapy may begin methadone treatment in the second trimester to reduce serious withdrawal symptoms in the infant at birth. The starting dose recommended is 20 to 30 milligrams per day. This can be titrated up to 5 to 10 milligram increments up to 120 milligrams per day as maintenance therapy. The ideal patient who would benefit from methadone would be an adult patient greater than 18 years of age who has been an opioid dependent for at least 1 year and has the ability to travel to office visits at a methadone treatment center. Many patients benefit from the structured treatment environment of a rehab facility because the patients have support system of healthcare providers to help motivate them through the process. When selecting a medication, it is important to consider the benefits and risks of each medication before starting therapy. Buprenorphine has many benefits such as high efficacy rates, many dosage forms with some in combinations with naloxone. Both buprenorphine and methadone are safe to use in pregnancy. Precautions to consider with buprenorphine include a short taper period, which could put the patient at a greater risk of precipitated withdrawal, and low doses are ineffective. Methadone therapy has the benefit of no risk for precipitated withdrawal. Some risks to consider with methadone therapy include a longer taper period, QTc prolongation when taken with other QTc prolongating medications, and poses a risk of diversion or abuse.